Good morning, everyone. Thank you so much, Dr. Frial, for the introduction. Thank you, Dr. Wiam, and the organizing committee for the kind invitation um, and coming to beautiful Bahrain to see the country. So this will be a follow-up lecture to yesterday's beautiful introduction to radiofrequency ablation. The objectives of the presentation are to discuss the RFA ablation for benign and toxic thyroid nodules, as well as radiofrequency ablation of thyroid cancer less than a centimeter, which is a recent indication from the American Thyroid Association. Maybe this should be a little bit further away. Yes, thank you. We will discuss patient selection criteria and potential risks and benefits of thyroid ablation. I have no conflicts of interest. So before we start, for people who are interested in further reading, there are really two good references for this talk. The first one is from the American Thyroid Association, like a task force or a guideline that was released in 2023. It's a very good reference on this topic. And there's another reference from Professor Beck from Korea, and this is on Endotext, and it's also a very good reference if you're interested. So there are multiple thyroid ablation techniques. RFA is one of them, and RFA uses high-frequency alternating current, which causes ionic excitation, and this leads to heat production, leading to necrosis with intracellular temperatures exceeding 50 degrees Celsius. And a commonly used ablation technique nowadays also is microwave ablation, especially for larger nodules. And this technique uses frictional heat. We are still using ethanol injection for predominantly cystic nodules, but laser ablation and high-intensity focused ultrasound ablation are becoming less commonly used. So what are the indications for RFA? So definitely for benign thyroid nodules, if there are neck compressive symptoms and if there are cosmetic concerns, we can use RFA for toxic thyroid nodules, also known as autonomously functioning thyroid nodules. It can be used in recurrent thyroid cancer at the thyroid bed or in cervical lymph nodes, especially if the patient is high risk for surgery or refusing surgery. And more recently, as late as last year, the American Thyroid Association has approved the use of ablation for intracellular small cancers, less than a centimeter. In general, we want to ablate benign nodules, which measure around 2 to 3 centimeters. It's unusual that we have to ablate small nodules, less than 1.5 centimeter. Usually they don't cause any concern. And very large nodules, especially if there are multiple nodules, may need multiple sessions. So this is something to be aware of. For toxic nodules, if they are smaller than 10 to 12 cubic centimeters or milliliters, they have excellent outcomes. Larger toxic nodules may again need more than one session. Surgery is preferred for multiple large nodules, especially if there's substernal extension or airway compression. Before we ablate, we have to make sure that the nodules are benign, because after ablation, it is very hard to go back and do, to do confirmation. So quite often we request or suggest that patients have at least 2 benign biopsies. However, one biopsy is okay if it is a toxic nodule or if the nodule is looking very benign on ultrasound, for example, spongiform nodule. What are some of the concerns, or if you like, relative contraindications when it comes to ablation? So if the nodule is more than a centimeter and it has indeterminate cytology, we may think twice about doing ablation. Now, what happens if we do molecular testing and the molecular testing is negative? So we need more studies about that. But essentially, if it's a cytologically indeterminate nodule, cancer is not excluded, so we have to be a little bit careful. If we have multinodular goiter with significant bilateral nodularity, substernal extension, I think surgery would be a much better option. If there's vocal cord paralysis on the other side that we are going to ablate, we have to be very careful because we don't want to give the patient bilateral vocal cord paralysis. For pregnancy, people with pacemakers or implantable defibrillators, we can do RFA, but we have to use a bipolar electrode. For patients with clotting or bleeding disorders, or patients who are unable to stop anticoagulants, we may have to reconsider. And absolute contraindications are if we have a malignancy more than a centimeter in size, or there's extrathyroidal extension on imaging, and also for nodules that are more than a centimeter, again, indeterminate cytology, but in this case, we have positive molecular markers. So here, the risk of malignancy would be a little bit higher, and we would fall back on surgery. Before RFA, we have to make sure that the indications are met, have a thorough discussion with the patients about benefits and risks, make sure that the nodule is benign, as we discussed. And here, I just want to mention very briefly that if we are going to ablate a large nodule on one side, and then you have a small nodule on the other side, but it's highly suspicious, you may want to consider doing evaluation of the small nodule because that may change management altogether. In that if it's malignant, the patient may not choose to do ablation at all. They may decide to go to surgery. We need to check thyroid function tests, make sure there's no coagulation problems, get a baseline ECG. I get the patient seen in ENT for vocal cord examination before we start, simply because up to 30% of patients may have subclinical or, if you like, asymptomatic vocal cord palsy. So it's very important to do that before we start. For large goiters and neck symptoms, I like to get a CT neck, looking specifically for tracheal compression and retrosternal extension. I'm not sure if you can see the diagram on the left. This is from the American Thyroid Association, but I just want to highlight that after we have done all the workup and inclusions and exclusions, we look at the composition of the nodule, and if it is more than 20% solid nodule, then ablation with RFA or microwave would be the way to go. But if it's less than 20% solid, alcohol is a good option, at least as a starting point. And you can always go back and do thermal ablation after alcohol if that doesn't work. It's important before we start also to assess the neck from a cosmetic point of view. This is a cosmetic score. So it's a 4-point system. 1 means there's no palpable mass. Number 2, there's no cosmetic problem, but there is a palpable mass. 3, there's a cosmetic problem only on swallowing. And number 4, it's a constant cosmetic problem. And quite often it's patients with scores 3 and 4 who will benefit from ablation. For patients on blood thinners, I usually refer them to the coagulation clinic for management of anticoagulation before we start. And it's important to get approval or to discuss the case with the neurologist or cardiologist as needed to make sure that the patient can come off anticoagulation for a period of time and then go back on it. The procedure is preferably done under local anesthesia, and this is much better than doing general anesthesia or deep sedation. It does provide adequate anesthesia for most patients, and it does permit early detection of complications, especially voice problems or skin burn. There are really lots of benefits of RFA, and I've listed some of them here. It's reduction in nodule volume, improved neck compressive symptoms, and cosmetic concerns. There's no neck scar, no need for thyroid hormone replacement. It's an outpatient procedure. The patient goes home on the same day, no general anesthesia. uh, Faster return to daily activities compared to surgery, but it's not for everyone. So unlike surgery, we do need long-term monitoring with ultrasound, and patients may need retreatment if there's nodule regrowth. This is the usual setup for thyroid RFA. So we have the generator on the left and the water pump, and then the the operator would be sitting at the head of the patient, um, and there's you can see the grounding pads and the electrodes, and the machine is operated using a foot switch. And this is the electrode. It can be bipolar or monopolar. Quite often it's just monopolar, 18 gauge, and the length of the needle is between 7 to 10 centimeters. And you can see here the active tip. It has an internal cooling system, and the active tip can be between 3 millimeters up to 15 millimeters. And the actual size of the active tip determines how much power can be used inside the nodule. And more recently now we have a variable tip size, which can go from 5 millimeters up to 3 centimeters. And this was introduced yesterday. It's the transismic and moving shot approach. Um, so the preferred approach is to go through the isthmus, because this really stabilizes the electrode and directs the electrode away from the danger triangle, which is that triangle here uh, where the recurrent laryngeal nerve sits in the tracheoesophageal groove. Um, so the nodule is divided into small units, and we usually start with the deepest unit. You can see there it's shown in number 1, and then we pull back. So you go in and then pull back very slowly. And as you pull back, you can see air bubbles forming in the area, and then you go into the next level and so forth. And what I wanted to mention is that the nodule, you can think of it like a sphere, and you're going to do multiple layers depending how big it is. It can be 2, 3, and sometimes 4 punctures depending on how big the nodule is. And then after that, it's the fan approach going from left to right. Okay, and this is again the danger triangle that we are trying to avoid. So in the upper neck, the recurrent laryngeal nerve sits in the tracheoesophageal groove. But once you go in the lower neck, so that's where inferior nodules, the recurrent laryngeal nerve, especially on the right side, can be quite lateral. So really, the posterior margin of the thyroid, is a danger area, if you like, and should be avoided. And this diagram is just to show you that there are variations in the anatomy in the neck. So if I can just show you is that the laser? Ah, sorry. Okay, yes, thank you. Yeah, so I'm not sure how to operate this, but basically this is the recurrent laryngeal nerve here in the groove, right? And as we move inferiorly, the recurrent laryngeal nerve can be quite sort of lateral, especially on the right side. So something to be aware of. The vagus nerve shown here in number two is usually next to the carotid artery, but in about 10% of patients, it can be anterior and medial. So if you are doing a nodule which is quite lateral, we have to be careful that we may damage the vagus nerve. And number three shown here is the middle cervical sympathetic ganglion, and again, it can be medial in a small number of patients. Quite often, it's posterior to the vasculature, but about 10% of patients it can be medial. So it's something to be aware of, so that we don't give the patient Horner syndrome. And this is one of the nice techniques with RFA. It's hydrodissection, where we inject chilled 5% dextrose between the nodule and surrounding structures. You're aiming for about at least 5 millimeter separation, and the injection may need to be repeated, and sometimes it's given as a continuous infusion during the procedure. During RFA, we may sometimes have to do vascular ablation as well. So if nodules have feeding arteries, the artery can be punctured and ablated, and this will help to reduce the heat sink effect of the ablation area, and allows us to use lower currents or lower power for the ablation. And after ablating the artery, if the nodule also has peripheral veins, the veins can be ablated as well, and this allows us to reach the margins of the nodule. And this is a picture from Professor Beck's uh, textbook, and it shows here a marginal vein on the superior lateral margin of the nodule. And after ablation, you can see the vein here. It's full of air bubbles. That it's called venous staining. But essentially, this allows the ablation to go as far as really the very lateral part of the nodule. So after ablation, we keep the patient in the clinic for about 30 minutes with ice packs and pressure on the neck. We check for any voice change, cough after drinking water, and on discharge, prescribe some painkillers. I usually get them to come back the next day just to check for any immediate complications, and usually follow up after 1, 3, and 6 months. And when we do follow up in the clinic, we're really looking at the volume reduction, which was discussed yesterday. So we're seeing, what's the change in the volume of the nodule after treatment. Okay, so let's discuss response to treatment. In about 85% of nodules, we can achieve volume reduction of at least 50% long term, more than 5 years. And quite often actually much higher than 50%. There's usually symptom improvement in the first month after ablation, but volume reduction may take a little bit longer. In a meta-analysis of 14 studies, which included 10 RFA studies and 4 laser ablation studies, they showed that so these are actually toxic nodules. So 71% of patients had normalization of TSH, and again about 70% had 70% volume reduction over about 13 months. This is a meta-analysis of volume reduction after ablation for benign thyroid nodules, comparing laser ablation and RFA. The meta-analysis had 12 studies, 5 for RFA and 7 for laser. And the RFA shown here in the dotted line is actually much higher than the laser ablation, which is the lower dotted line. So for example, 6 months, we had 65% volume reduction in the nodule size. At 12 months, 77%, and at 3 years, 92%. And in that meta-analysis, which is interesting, after 3 years, there was actually even further reduction with RFA in nodule volume, and that was not seen with laser. So laser is gradually sort of falling out of fashion, and RFA and microwave are now more commonly used. This is another meta-analysis comparing RFA to microwave ablation for benign thyroid nodules. It had 9 studies, and there were 1,300 nodules in each arm, microwave and RFA. And it shows the volume reduction was similar at 1, 3, and 6 months. But at 12 months, RFA volume reduction was significantly greater than microwave ablation. So let's talk a little bit about complications, and it's always important to prepare patients and tell them what can happen after ablation. It's not common, but we can have injury to surrounding structures, including trachea, esophagus, recurrent laryngeal nerve injuries. So recurrent laryngeal nerve injuries can occur in about 1.4% of patients, but it's much higher in patients with recurrent cancer because the ablation will be usually in the central, near the central compartment. So in one meta-analysis, up to 8% of patients had recurrent laryngeal nerve injuries with those ablations. Injuries to other nerves in the neck is relatively rare. In toxic nodules, we may sometimes see transient hyperthyroidism, which is a form of destructive thyroiditis after ablation, especially for larger nodules. And we often instruct patients to continue taking antithyroid medications for 3 to 4 weeks after ablation, and then to consider beta blockers if they develop tachycardia. For neck compressive symptoms with very large nodules, we may have to resort to tapering steroids after ablation. And this is again from Professor Beck's data showing complications of RFA. So the overall number of complications is about 3.3%. Major complications, which includes voice change, nodule rupture, hypothyroidism, and brachial plexus injury, was about 1.4%, quite low. And the patient who developed hypothyroidism had antibody positivity before RFA. These are minor complications like hematoma, vomiting, and skin burn occurring in less than 2% of patients. So overall, very, very safe procedure. Immediate complication management. If the patient during the procedure develops hoarseness of the voice or sudden cough, this may signal recurrent laryngeal nerve injury, and the area is injected with chilled 5% dextrose, and immediately this will reduce the temperature in the area. Hemorrhage is usually managed just with compression, and if there's arterial hemorrhage, this can be actually ablated during the procedure. Nodule rupture is uncommon, but it can occur after 2 weeks or longer after the ablation. The actual mechanism is not very clear, but it's thought to be microvascular leakage. We don't really know the risk factors. I have seen only one case in my practice. Usually it's conservative management, but we may need to aspirate the fluid and sometimes use antibiotics. So in this image here, this is a patient who had ablation, and after 156 days, there was bleeding around the ablation area. and it resolved spontaneously with conservative management. Nodule regrowth is an issue, especially with large nodules. And there are varying definitions of nodule regrowth. The most common one is more than 50% increase in nodule volume from the minimum volume that was achieved after ablation. The average increase in size after, or the average rate of regrowth is about 12%, but it can be up to 40%, especially with larger nodules, nodules that are close to critical neck structures where ablation cannot actually go right to the area that we need to ablate. We may consider retreatment if the volume reduction is less than 30% at 6 months, or if there's regrowth in peripherally untreated areas. Now, significant changes in thyroid function are rare, and we usually monitor thyroid function once or twice after ablation, and then we don't continue long-term monitoring of thyroid function. And again, as was discussed yesterday, we can't really use TIRADS or ATA classification after ablation. The nodules will be hypoechoic, they will have irregular margins and echogenic foci. And in studies that were done, they showed that ATA high suspicion features increased from 3% to 20% in ablated nodules, and TIRADS 4 and 5 went from 40% to 70%. So it's very important to inform the patient that if they are seeing any other physicians to tell them that they've had an ablation, because this will really change the equation. Okay, so what about low-risk thyroid cancer? This is a retrospective study with more than 10 years of follow-up from Korea. They evaluated parathyroid microcarcinoma after RFA ablation in 65 patients who were either unsuitable or declined surgery. And the number of patients were 65, the tumors were 71. The average age was about 45.8 years, and the follow-up was 151 months. Only 5 out of the 65 patients had more than one tumor. The others had only one. And if you look here at the bottom where I've underlined a couple of items, so the number of treatments in 80% of patients was only one, a single treatment, and about 18% of patients needed more than one treatment. The ablation time is impressive. It's 150 seconds, so it's less than 3 minutes. And this is what happens after ablation. So you can see here the tumor, after ablation, the tumor blows up in size. It's actually, there's like a 4.5-fold increase in size in the first month. And then after 3 months, the nodule returns back to baseline and gradually disappears. But essentially within like 2 years, the nodule was absent. It was not seen. And this is data from the same study showing that at 2 years, the volume reduction ratio was 100%, and this was maintained up to 10 years. And complete tumor disappearance rates were 75% at 12 months, and then 100% at 2 years. 20% of patients required more than one treatment, and 7.7% of patients developed a new cancer, which was also ablated in 4 patients, and 1 patient had a lobectomy. But importantly, none of the patients had tumor progression or metastases during 10 years of follow-up. But unlike surgery, these patients will need long-term follow-up, especially looking for lymph nodes, metastatic lymph nodes, or things like that. So to conclude, RFA for low-risk thyroid microcarcinoma demonstrates long-term efficacy and safety in highly specialized centers. Of course, the results may be different in less experienced centers. And this is now in the 2025 ATA recommendation that it can be an option for low-risk cancers. Okay, so if you're thinking about starting RFA for thyroid nodules, it's good to have experience with ultrasonography of the thyroid and biopsy. Proficiency is usually achieved after 60 ablations, and major complications would be much lower after more than 100 ablations. Usually start with small nodules, non-vascular, and mid-thyroid location. Yeah, so essentially I was just going to show you the conclusion slide, but thyroid RFA is yeah, so this is the conclusion slide. So thyroid RFA is safe and effective for benign nodules, toxic nodules, and small cancers. Very low risk of complications, no need for long-term hormone replacement. There's no risk of hypoparathyroidism. Uh, you may need more than one ablation for large nodules, bilateral nodules, especially large toxic nodules. There is a risk of regrowth, and long-term monitoring is required. And for small cancers, very high cure rates in experienced centers. Thank you so much.